Welcome to the University of Michigan Sound Support's 2023 Parent Webinar Summer Series. This is a bonus webinar to go along with our summer series. My name is Amanda McGuire, and I am the Sound Support Coordinator for the University of Michigan's Cochlear Implant Program. As you may know, Sound Support is an outreach grant funded by the University of Michigan Department of Otolaryngology and Michigan Medicaid. The grant is designed to provide outreach and support to children with hearing loss and their families throughout Michigan. We put together this series of webinars for parents due to the great responses from past series. If you have any questions, please email Sound Support at oto-soundsupportci@med.umich.edu. Today's parent webinar is titled Mythbusters 3.0, Hearing Aids and Cochlear Implants. I would like to take the opportunity to introduce our presenter today, Dr. Casey Stach. Dr. Stach is an audiologist in our Cochlear Implant Program. With that, I'll hand it over to Dr. Stach and we'll get started.
Hello, everyone. My name is Casey Stach. I am a cochlear implant audiologist at the University of Michigan, and today's webinar is titled Mythbusters 3.0. We've done this a few times in the past and thought it would be worthwhile to repeat. And today I'm going to talk about some of the myths or concerns or questions we sometimes get in the clinic regarding hearing aids and cochlear implants. We're going to discuss the common myths regarding hearing loss, hearing aids, and cochlear implants. I just want to show you my disclosures. So hearing loss is one of the most common health-related problems in America, with an estimated 36 million people in the United States that have some degree of hearing loss. Of those 36 million, approximately 1.2 individuals have severe or severe to profound hearing loss, making them potential candidates for a cochlear implant. And we also know that 2 in 3 children out of every 1,000 births are born deaf or acquire significant hearing loss. And of those identified, 90% are born to hearing parents. Yet only 1 out of 5 people who could benefit from hearing aids actually wear one. And according to the National Institute on Deafness and Other Communication Disorders, although the 1.2 million people in the US are candidates for a cochlear implant, only approximately 183,000 adults and children in the United States have one. Worldwide, about 700,000 people have received a cochlear implant, and I want to note that their data has not been updated since 2019, so the numbers might be slightly higher. But the question remains, why? Why do so few people who could benefit from this technology do so? And we think that unfortunately, many people still don't know that the technology exists, or their primary care doctors are not aware of current candidacy requirements and may still think that patients have to hear very little with their hearing aids in order to be a candidate. Or is it because of some of the myths and misinformation out there on cochlear implants? The internet is a busy place, 2.3 million searches per second, with over 1 billion searches monthly and 2 trillion searches annually. Yet sometimes it's difficult to determine how much information on the internet is fake, and fake news has really dominated the news headlines over the past several years. And some of the information that is online is alarming. And this is important because 40% of Americans get their news or information online. And even more alarming, only 38.5% of web traffic is from humans, where 61.5% is from bots, impersonators, hacking tools, and spammers. So we have to be aware of what is considered a reliable source. So let's dive in. Myth: you cannot fit young babies with hearing aids. And that is false. Hopefully everyone knows that most states have newborn screening laws that require that all babies be screened for hearing loss when they're born. We also know that 1 to 2 babies out of 1,000 are born with significant hearing loss at birth who were not at risk. And that means that 50%, or roughly 6,000 babies, were being sent home with undetected hearing loss or not getting identified until they were 2, 3, or maybe 4 years of age, putting them behind their hearing peers in language, cognition, and social skills. But the good news is, in the early 1990s, the NIH held a consensus conference that, in a landmark move, endorsed the screening of all newborns for hearing loss before they leave the hospital. Many states followed with creating initiatives following this mandatory screening. And it resulted in Congress passing the Newborn and Infant Hearing Screening and Intervention Act of 1999, which helped in the coordination of funding statewide programs. So today, all states have established early hearing detection and intervention programs. And of these, 43 states plus the District of Columbia and Puerto Rico have mandated newborn hearing screening programs, with current data indicating that 98% of all newborns in the US are screened for hearing loss at birth. Today's goal recommendations by EDI include all newborns will be screened for hearing loss before 1 month of age. All infants who refer on their screening will have a full diagnostic audiological evaluation before 3 months of age. And all infants identified with hearing loss are fit no later than 6 months of age. All right, myth. Cochlear implants are FDA approved and are not considered experimental. That is true. Cochlear implants are FDA approved. They are not considered experimental. You can see the 3 FDA approved cochlear implant manufacturers here in the United States and the year they were founded and the year they received FDA approval. Myth, cochlear implant surgery is brain surgery. This is false. The electrode array is placed inside the cochlea and the receiver stimulator is placed under the temporalis muscle behind the ear. And at no time is the brain exposed, touched, or probed. Here is just an anatomical model we have in the clinic to show people where the internal device goes. You can see that the receiver stimulator is between the temporal bone and the temporalis muscle you see here. This pink portion indicates the brain, and you can see that the device does not come close. Cochlear implant is major surgery. This is false. Although patients are put under general anesthesia, the surgery itself takes 2 to 3 hours, and most patients have surgery the same day and then go home. Many do not need to stay in the hospital overnight, and most can resume activity within 3 to 5 days after surgery. And here are just a couple of pictures of the kids who've had surgery in our clinic, and I wanted you to see what it looks like when they come out of surgery. There is a pressure bandage that is placed over their ears, and this is their ear, which is designed to help reduce swelling. Myth, you can only have cochlear implant surgery once in your lifetime. And that is false. Internal devices are made out of titanium and celastic. These materials are completely compatible with the body. And the hope is that that internal device will last a very long time. In many adult cases, the internal device will last their lifetime, depending on the age at which they were implanted. However, when I do counsel families of young babies considering cochlear implantation, I do not tell them that the device will last the baby's lifetime. It is highly probable that if a baby is implanted at 1 year of age or 9 months of age, and they live until they're 80, 90, or 100 years, they will most likely need a new cochlear implant at some point. This is not due to growth. The mastoid bone is mature enough at 1 year of age to house the internal device and allow for growth over time. I think it's important to remember that cochlear implants have only been FDA approved for almost 40 years for adults and 35 years for pediatric patients. So I don't think we actually know how long internal devices will last. I often tell patients that we don't expect hip or knee replacements or pacemakers to last 80 years. So it's unrealistic to think that a cochlear implant would last that long. And finally, devices can fail, but the failure rate for cochlear implantation is very low, typically less than 2%. And if a device fails, then the patient is explanted and then re-implanted with a new one. All right, myth: cochlear implants destroy residual hearing. This is true and false. Early electrode designs did destroy residual hearing for most patients, but if they were understanding 0% and had profound hearing losses, they weren't sacrificing much and were willing to take the risk of losing what little hearing they had for potential benefit from a cochlear implant. And early on, it was not uncommon to see an audiogram preoperatively that looked like this, where there really wasn't much residual hearing. And just as a reminder, an audiogram depicts frequency across the top, so low pitch to high pitch. And this axis represents a loudness in decibel levels, so very soft to very loud. Anything 90 decibels and below is considered a profound hearing loss. So this audiogram demonstrates someone with really not much residual hearing in either their right ear depicted by the circles or their left ear depicted by the X's. The electrode designs have changed significantly over time and are thinner than previous models, which have allowed for hearing preservation. So if we are implanting patients who still perform poorly on speech recognition tests, but may have more residual hearing. There's no guarantee of hearing preservation, but it can and does happen. Additionally, having hearing preservation allows us to possibly connect an acoustic component to their sound or speech processor. So we can activate acoustic amplification at frequencies, typically in the low frequency end, if there is hearing to amplify. So here is a preoperative audiogram of one of our patients, which shows quite a bit of residual hearing from 250 hertz to 1,000 hertz right here. But he wasn't understanding much speech, even with appropriately fitted hearing aids. And so he opted for a left cochlear implant. And here is his audiogram comparing his preoperative and postoperative thresholds the day of his activation. So you can see it's pretty symmetrical. He had a bit of a drop here at 500 hertz, a little bit here at 750, and a tiny bit at 1,000. But remarkably, his hearing was pretty stable. These were his preoperative speech recognition scores with his left hearing aid. You can see with CNC monosyllabic words, he was only understanding 24%. On AZ bio sentences, 51%, and with the presence of background noise, only 27%. So he wasn't doing very well with his appropriately fitted hearing aids, and his scores increased dramatically with his cochlear implant. As you can see, 96% on sentences, quiet, and 92% in noise. And remarkably, his audiogram is very stable. Even 2 years post-implant, you can see that his hearing thresholds in the ear that he has his cochlear implant have remained fairly stable. So again, there's no guarantee that hearing preservation will occur, but surgeons typically do their best to preserve hearing if possible. All right, myth: cochlear implants do not restore hearing to normal. That is true. Cochlear implants are a prosthetic device. They do not restore hearing to normal, but it is an amazing technology that allows people an option of better hearing should their hearing aids not be doing the job. And what they do is try to compensate for the loss of hair cell function in the cochlea. So sometimes adults will come in and say, I have nerve deafness, and that's actually not true. The nerve is typically intact, but the hair cells that are innervating the nerve and transmitting the sound have been damaged for whatever reason. So the nerve is still there and intact, and the cochlear implant is basically taking the place of the damaged hair cells and stimulating the auditory nerve directly. But what does it sound like? The cochlear implant, although it doesn't restore hearing to normal, it must sound very close to what we perceive sound to be. Adults will tell us that after they've adjusted to their cochlear implant, that their husband, their partner, their child, their voices sound very similar to what it sounded like prior to their hearing loss. Initially, sometimes patients will report that it sounds a little robotic, but if it sounded robotic, then children's speech production would sound robotic because what goes in is what comes out. And when we implant babies as young as 9 months of age, they've never heard normally, so they don't have anything to compare it to. And so if you listen to their speech after they've had their device 4, 5, or 10 years, and they got their cochlear implants early, their speech sounds very much like yours and mine does. So it has to sound very close to what we hear. All right, myth. You can have an MRI with a cochlear implant. That is true. Most patients have internal devices that allow some MRI compatibility. There are some older internal devices that do not allow MRIs. And we always recommend that the cochlear implant patient either check with their cochlear implant center or their manufacturer to determine if they have an MRI compatible device. But a number of years ago, all 3 manufacturers did change their magnet design in the internal devices that now allow MRIs up to a 3 Tesla. There is still some shadow effect with the magnet in place, but it's amazing that these patients can take advantage of that diagnostic imaging if they need to. And these 2 images just show you what the MR looks like with a 3 Tesla weighted MRI with the magnet in place. And if they remove a magnet, they can take the magnet out and put it back in after the MRI, and the image is pretty clear. All right, myth. You can wear a hat or a helmet with a cochlear implant, and that is true. Along those lines, we often have questions regarding playing sports with a cochlear implant. And sometimes we hear, oh, you can't play a sport if you have a cochlear implant, and that is false. You can absolutely play a sport if you have a cochlear implant. We have firefighters who wear wildlife style helmets, a welder who modified his helmet to accommodate his speech processor. And I have children that play every sport imaginable and will modify their helmet so that they can wear their device if they want to while they're playing. Regardless if you have an implant or not, helmets are recommended for all contact sports. And the rule of thumb is if you play a sport where a helmet would be wise, wear the helmet. Here's a picture of a football helmet. This football helmet company, Riddell, made a helmet they used to call and may still call the Revolution. That is inflatable and provides a flexible fit over hearing aids and cochlear implants. And you can see this patient's cochlear implant right here. And there's his transmitting coil right there. I have, as I said, patients who play every sport imaginable: baseball, soccer, football, hockey, swimming. These 2 athletes shown here have been fairly vocal about their ability to play sports with their cochlear implants. Claire Stancliffe, who received a cochlear implant once her hearing aids were no longer beneficial, plays soccer for a league in the United Kingdom. Hunter Taylor, who was born with his hearing loss and received an implant as an infant, competed at the 2016 World Deaf Volleyball Championships with Team USA and at the 2016 Pan Am Games. Here are 2 of our very own cochlear implant patients at the University of Michigan. Molly, who you see in the picture on the left and the bottom right. She was featured in the Detroit Free Press in March of 2017 and on our local news. She set the Michigan High School Powerlifting Association record in the bench press category, pressing 190 pounds. She also played softball and is a swimmer who competed in the Deaf World Championships. She is in college getting a degree in civil engineering and then is pursuing a master's degree in architecture. And Tim, who's another one of our patients, has competed in 11 Ironmans. And here he is crossing the finish line. And you can see his cochlear implant right there on his right ear. This is another one of our patients, Jack, who's a bilateral cochlear implant user. He played goalie for his high school lacrosse team, and also played lacrosse in college. All right, myth. If you have a cochlear implant, you can wear a hearing aid in the opposite ear, but the sound will not be confusing. And that is true. In fact, we encourage bimodal hearing. So if a patient can wear a hearing aid in their opposite ear and can still benefit from it, we do recommend continued use. Studies have shown that patients can hear better in background noise with two ears, and their ability to localize sound is better with two ears. Additionally, most patients appreciate music if they have if they're using two ears, and will report a more natural sound if they have an implant in one ear and a hearing aid in the other. Myth: not everyone hears with a cochlear implant. That is false. The implant works, period. How well a person performs with the implant varies based on their hearing history. So a patient is deemed a candidate based on their preoperative testing, their imaging, whether that's an MRI or a CT scan, and we can confirm that an auditory nerve exists. They will hear with the implant. But as I said, their performance will vary, and that is all dependent on several factors. These factors are probably the biggest ones that will affect performance with a cochlear implant. The two biggest factors that influence performance are the age of the onset of hearing loss and the age of implantation. The amount of residual hearing, meaning if they had enough hearing to use hearing aids and were consistent users of their hearing aids, that also will play a role in how well they do with their implants. But of course, other comorbid or multiple handicapping conditions will also affect their motivation, their device use, and so on, all play a role in how well someone will do with a cochlear implant. If poor performance with a cochlear implant exists, we need to investigate why progress is not being made and see if there is a problem, and how do we intervene. So counseling preoperatively is the key, as we try to keep expectations low if their hearing history suggests that they will only improve detection abilities with an implant. But if their hearing history suggests that they should do well and understand speech and they're not, we need to investigate why, or why they are not making progress. So if a patient is not making appropriate progress with their cochlear implant, this is just the list of things we do here in our clinic to help determine the cause of poor performance. We also recommend the things listed here, which help us evaluate good or poor performance. Is it from the get-go, or did something occur over time that is causing their performance to decline? All right, myth: there is no hurry. You can wait until the child can decide for themselves to get an implant. You can let the child decide for themselves when they are older. That is true, but, and this is the key, if you decide to wait and let the child choose for themselves, then their outcome with their cochlear implant will be very different than if they proceeded during that critical period of brain development when the brain is most plastic and at its greatest potential to develop those auditory pathways. We know the longer you wait, the less benefit you're going to receive. So if a child is implanted early, they have a very good chance of developing normal speech and language skills. And if you wait until they are older, they're going to hear with a cochlear implant, but they're not going to understand. And this is due to how the brain is wired and its neuroplasticity early in life. So the brain operates on a use it or lose it philosophy, which means the brain recognizes itself when an area is not used for typical purpose. So if the brain has its greatest plasticity from birth to about 6 years of age, where language learning is at its greatest, we know that they're going to do better with a cochlear implant. And those auditory pathways will be stimulated early. To think about hearing is to think about early auditory stimulation of the brain. And, we hear with our brain. Your ears are just the doorway or the access to the brain. So if listening and spoken language are the goal of the parent or caregiver of a child, and the access to sound cannot be achieved by appropriate hearing aids, the only way for the brain to reach that potential is a cochlear implant. And the ideal time is prior to the ages of 2 to 3. So the earlier, the better the outcome, plain and simple. And we have seen this in our clinic. So here's a slide that was published by our speech language pathologists who are listening and spoken language specialists and have a specialty certification in auditory verbal therapy. And this test is showing the receptive word understanding along the y-axis, the percent correct, and versus the years post implantation. And so those children that were implanted under the age of 2, you can see that their speech recognition or speech receptive word score is significantly higher and continues to grow even 8 years post, compared to those children that are older. Their outcomes are just poorer despite the fact that they have had their implants for the same amount of time. So that early neuroplasticity in the brain makes a significant difference on performance. All right, myth. Part-time use of my cochlear implant is better than no use. And that is false. It's just as bad. Cochlear implants are very different than hearing aids and cannot be worn part-time if benefit is expected. And we are able to guide families, adults and children, with the use of a tool called data logging. We can determine how long patients are wearing their devices and determine if it's a retention issue. Do the parents need some suggestions on how to keep the devices on? What is the reason they're not able to keep their devices on full time? So this is just the top right ear you can see is just a graph that depicts, we can determine that this patient is wearing their device about 14 hours a day versus this person with their left ear, they're only wearing their device about 3.2 hours a day. So if poor performance is occurring, this is one of the reasons. You need to wear your device full time in order to achieve your maximum benefit. Myth. You can get a cochlear implant if you are, quote, old. That is true. There is no upper age limit to receive a cochlear implant. As long as the adult is healthy enough to undergo a 2 to 3 hour surgery and they qualify for a cochlear implant, they can get one. And it really is a quality of life issue. If an adult has had a progressive hearing loss their entire life, and they are significantly hearing impaired, and I think at their later years, that's when they should be able to hear their family friends with whatever remaining time they have. In fact, the oldest person to receive a cochlear implant was Molly Smith from England. She received a cochlear implant at age 99 in 2014. She believed she started losing her hearing after being exposed to the excessive noise due to the bombing during World War I. She went completely deaf at age 70 and reported after getting her implant that it changed her life and it gave her a new lease on life. Here at the University of Michigan, the oldest patient we've implanted was 98. Myth. Most people are getting 2 implants. That is true and false. I would say that most of our pediatric patients do get bilateral simultaneous cochlear implants. We know that we hear better with 2 ears. We also know that their academic performance is going to be better when they have 2 ears because classrooms are incredibly noisy. And with 2 ears, you are able to localize where sound is coming from, and you do understand speech better in the presence of background noise. most of our adults will start with one cochlear implant and then proceed with a second implant. So though most often that happens with our adults, unless there's a medical reason to do two simultaneously. All right, myth, you have to shave the area under the magnet. That is false. Magnets do come in varying strengths, and the strength is determined by the thickness of the patient's skin flap. So everybody's muscle that covers their whole head varies in thickness. And so magnet tightness is determined, or how tight we need the magnet to be is determined at activation, and then checked at our center at every visit to ensure that it's not too tight or it's not too loose. Myth, cochlear implants are way too expensive. That is false. It is an expensive device, but cochlear implants are a covered benefit under insurance plans, including Medicare and Medicaid. They are not qualified in the same category as hearing aids. They are prosthetic implantable devices and are covered by insurance plans. Earlier, we mentioned that hearing loss is one of the most common health-related problems in America, but it is also the most costly disability when we look at lifetime costs to provide intervention and special education services. The average lifetime cost to society of a child born deaf in terms of medical education and productivity is over $1 million. And if we look at the cost of education in the state of Michigan, it costs approximately $9,600 per student who has no special education needs, roughly $12,300 for a hearing impaired child in a self-contained classroom. And that varies by county because each county or ISD determines how much extra they're going to allot for children on an IEP or a 504. And the Michigan State School for the Deaf is over $41,000 annually. And you add those costs from kindergarten through 12th grade, and you can see the cost of educating children with hearing loss can be staggering. Multiple research articles have been published demonstrating the cost effectiveness of cochlear implantation. They have looked directly at medical costs, pre and post-operative services, and the indirect costs, time off work, travel expenses of the parents, educational costs that we just talked about, as well as effects of future earnings. And all of the studies have shown that cochlear implants are one of the most cost-effective medical treatments of our day. It's even more cost-effective than coronary bypass surgery or kidney dialysis. All right, myth. Patients are not fully mapped until 3 to 6 months of device use. That's false. We hear this a lot. Oh, well, they're not fully mapped yet. They are fully mapped at activation. So remember, we hear with our brains. Our ears are just the instrument that deliver the sound to our brains. Even though they are fully mapped on day one, they still have to learn or relearn what sounds are and associate meaning to them. And we want sound to be comfortable. And if wearing their device consistently from day one, once you give the brain a little bit of sound, they're going to want to increase the amount of sound. And that is what is done over several months from activation. But at activation, all electrodes are activated and they are hearing. Myth, patients are turned up at every visit, and that is false. As I just said, we are typically increasing the amount of sound a patient gets, but usually by 1 to 3 months, sometimes 6 months post-implant, their range of sound that the brain is getting remains pretty stable. And we do know that louder is not better. We are seeking clarity of speech. And so if we have appropriate sound being picked up by the implant and sent to the brain, then we are just allowing the brain to get used to sound and associating meaning with what they're hearing. Myth, patients choose which device they get. Actually, they can. Patients or parents can choose between the 3 FDA-approved cochlear implant systems in the US. At the University of Michigan, we do work with all 3 FDA-approved devices, and patients and families are given the choice of all 3. At their final appointment prior to surgery, the devices are reviewed and the features of each system are discussed. And based on their specific needs, we do help them determine which device might be best for them or their child. We include a discussion about accessory options, warranties, customer service, and device reliability. One of the biggest things over the past several years with cochlear implants is streaming or Bluetooth accessibility. And so how a patient streams music or phone calls or videos is usually the deciding factor to which device they go with. These are some of the other considerations that we discuss. The things you see at the top, the audiological considerations, are things the audiologist might discuss. The surgeon might also have an opinion on what device to implant, and that is discussed prior to surgery as well. All right, myth: cochlear implant users must stay away from Wi-Fi devices due to interference. And that is false. Wi-Fi or FM frequency modulation will not interfere with a cochlear implant. In fact, some processors use a form of Wi-Fi to communicate with other accessories. Myth: I get this a lot. You can leave your implant on when you go through airport security, and that is true. The TSA recommends that you leave your hearing aid and or cochlear implant on when going through security. You can certainly inform the TSA officer that you're deaf or hard of hearing, and that you may require some assistance with the screening process, but you are not legally required to remove your hearing aid or cochlear implant when walking through security machines. Myth: you can go swimming with your cochlear implant on. That is true. All 3 manufacturers have aqua accessories that allow them to go swimming. And they all have some degree of water resistancy, even without the aqua accessory on. And if you want more details on IPF ratings, you can go to the implant manufacturer's website and they will discuss their IPF ratings for water resistancy. All right, myth: cochlear implant users cannot hear music. That is false. Cochlear implants users can hear music, but I would say the degree to which they appreciate or like music really varies. Adults who had normal hearing and then lost their hearing and received a cochlear implant will sometimes report that they don't like the way music sounds with their implant, but some really do. And I have many musicians, adult musicians, that still appreciate music with their cochlear implant. For the pediatric population or the children, they like and listen to music just like you and I do, and are oftentimes coming into my office streaming music from their smart devices. And that's most likely in part because they never heard music normally, so they don't have anything to compare it to. Lots of people with cochlear implants play musical instruments, as you can see here. And I have patients and adults alike who play every musical instrument under the sun. This is Samuel. He is one of our cochlear implant patients. He has bilateral cochlear implants. He was implanted as a baby. And I'm just going to play a portion of this for you. This was very thankfully provided by Samuel's parents. This is his piano recital. And I just want you to see what someone with an implant can do with music. So I'm going to start the video, but it's quite a long piece. So I'm going to start it so you can hear the beginning. I'm going to jump to the middle and then I'm going to stop.
And I'll be playing Lovers to Row.
So that's pretty amazing. Sam, has as I said, bilateral implants. If you do follow our Facebook page, you can also search because the entire song is on our Facebook page if you would like to see it further. And finally, I just would like to end this presentation with a very short video of one of our little ones. So you saw Sam, who, is a teenager and has normal speech and language skills and playing the piano. But this very short video is from one of our little ones. In this video, she's 17 months of age. She's had her cochlear implants for 4 months of age and received auditory verbal therapy at our center. Her mom sent us this video showing us what she was doing at home with only 4 months of sound.
What letter's that? What's that? Good. O. Look. What's this one? What's this one? S. Good. What's this one? E. Good girl. What's this one? What's this one? Good girl. M. What's this one? Good girl.
So thank you for taking the time to watch the Mythbusters 3.0. Should you have any questions regarding this presentation, feel free to email us at otosoundsupportci@med.umich.edu. And again, thank you for your time.